Hello, I'm Konstantinos Charitakis. I'm an assistant professor of medicine and cardiology in University of Texas Medical School. Thank you for this very kind invitation to this conference. And I'm going to present a very interesting case of an ST elevation MI that we treated with an Amplatzer device rather with a stent. It was a 72-year-old gentleman that he presented in outside hospital with shortness of breath and syncope after a long flight. He was hypoxic, hypotensive, and he was intubated. For high probability of pulmonary embolism, he received thrombolysis, and then he was transferred to our hospital on high pressure requirement for a higher level of care. The CT, obviously, as you see, showed a large thrombus in the pulmonary artery and RV involvement with strain. And he went in the MICU. After the thrombolysis, though, he developed acute chest pain, ST segment elevation in the anterolateral leads, and a stat echocardiogram showed severe anterior wall hypokinesis, an EF of 25%, and evidence of intra-atrial communication. He was taken emergency in the cath lab, and as you see in the angiogram, there is a large amount of thrombus in the LAD and in the diagonal. This is the angiogram after the thrombus aspiration. As you see, we have an excellent result. No stent was placed. And we were wondering, what should we do about this gentleman? That's most likely a thromboembolic event. Should we put a stent or not? And we decided to do OCT. And as you see, very interestingly, there was no plaque at all in the left anterior descending. And actually, there was not even any evidence of plaque rupture after the aspiration. So at that point, we decided, and this is a thrombus that was aspirated, we decided that most likely this is a thromboembolic event, probably a DVT after a long flight. The clot traveled up to the right atrium and to the left atrium through the PFO, from the left atrium to the left ventricle, aorta, and LAD. Very unlucky guy. For this reason, given the absence of plaque in the OCT, we decided not to stent the patient. We took him back in the CCU and we tried to evaluate that PFO better. We performed a transesophageal echocardiogram that showed the evidence of PFO. Patient was extubated, he came off the pressors, and actually we got the pathology of the specimen that showed thrombus and no plaque. Next day he came in the lab. This is the image of the eyes that showed the PFO, and we closed the PFO with an Amplatzer device. He continues to be my clinic patient in 6 months and a year. The patient is completely asymptomatic. His ejection fraction normalized. He stayed on anticoagulation for 6 months for this provoked DVT and PE. And we really believe this is an interesting case of paradoxical embolism in the coronary arteries that was treated only with aspiration thrombectomy and without putting a stent. Thank you very much.